When you are ready.
You're fine there. All right, welcome everybody. I'm going to welcome, we're going to be Facebook live streaming this as well. We have a lot of patients, about 25% of our patients come from out of state, Kansas, Nebraska, Utah, California, Texas, all over the place. So we have a lot of people that want to get this information, but are not able to make it. And even tonight, for those of you that are out in the internet, it is snowing in Colorado. So thank you all for coming this evening and braving the snow. So for those of you that I have not met yet, my name is Dr. BenGalyardt, and I run this office. It's the Functional Medicine Center in Fort Collins, and I have been here for 15 years. We practice what is called functional medicine. Functional medicine is a way of looking at the body as a whole and figuring out why it is going haywire. So many of you here tonight or listening out there are here thinking about your thyroid, and it's a very common issue. Do you guys know what the #1 prescribed medication in the U.S. is? Levothyroxine. That's right. Yeah. Over 20 million people are on, and Synthroid would be that generic, non-generic name as well. So Synthroid, levothyroxine, over 20 million people are on that medication, #1 prescribed medication in the U.S. So the thing that I always like to talk about when we do these thyroid workshops is that you are here, or you are listening because someone told you your thyroid is off. Blood work, you filled out a symptom survey one time, you're like, ooh, that sounds like I've got thyroid problems. Somewhere, somehow, you've got this idea that your thyroid is off. And for a lot of you, that probably is the case, and I'm going to show you how that physiology works, how everything plays into does your thyroid affect the rest of your body. But for probably 80% of your symptoms are not going to be directly related to your thyroid. If anything, a lot of these other issues are actually harming the thyroid. And that's where functional medicine comes into play, is that it's not just about what can we do naturally. Hey, let's give you some iodine, some thyroid herbs, whatever it is. None of that is going to fix you. I always tell patients, there's no amount of supplements that are going to fix you. We don't give you a bag of 20 things and say, go home now, don't even eat, just take all these pills. That's not going to fix you at all. What is going to fix you is figuring out the underlying whys. Which systems are out of balance? And it could be your liver, it could be your digestion, it could be your brain, you could have an underlying infection, you could be anemic, you could have high iron. We see more people with high iron than we do with low iron. But what does that mean? To the traditional medical office, oh, well, you know, if it's really high, you have hemochromatosis and you have to give blood. But what does it mean to be just on that borderline high iron? There's different things that we see with those patterns as well. So from that functional medicine perspective, we have to come up with the whys. And so a lot of you guys might be sitting here thinking, how did I get to this point? 15 years in this office. I've been practicing since 2001. And I started out all the way back in Syracuse. I did my undergrad in health and exercise science, went to chiropractic school in Dallas, and have been practicing the functional medicine side ever since. And what brought me into that path of truly figuring out those underlying imbalances and fixing it on this metabolic side, a big part of that was way back when I was a junior in high school. And my mom collapsed during one of my football games, and they ended up figuring out she had MS, had to go on disability. She was a school teacher my senior year. She was at home, just kind of puttering around, couldn't really do much of anything, would get exhausted, even walking around the grocery store, anything like that. Got to a point where she had to use a cane, would get in her scooter at Walmart and go shopping around, having to do those things, was on every medication there was in the 90s for MS, and wasn't getting better, was actually continuing to go downhill. And that's interesting. If somebody, and I was in college at that time, and if somebody is taking all the medications but not getting better, what's the deal? There's got to be something else. And so she ended up working with a great doc that went down this path of figuring out what those underlying imbalances were. She got off all the medications, was able to get to the point where her last MRI, probably 20 years ago, had no more plaquing, no more MS. Neurologist said, hey, if you were on the latest drugs, it'd be a success, but she wasn't. So it's just random luck. She's now 76. She does grading boot camp, fishes in Alaska, babysits my 4 boys, has no more MS. You can move it forward a little bit there. Yeah, there you go. So she no longer has MS, and that is pretty much a miracle for a lot of people. If you know multiple sclerosis at all, that doesn't happen. It doesn't just go away, but it did. And she cleans the office. She'll pick up weeds outside, puts up decorations. She'll bring rhubarb in the spring. She's active, functioning. And so at that point, it was how did that happen? How can the body truly heal? If we can heal from that, we can fix what's going on to our thyroid, we can fix what's going on in our gut, our brain, any of these different things. And that's the miracle of what we get to see every day in this office. And that's why people come from all over, so that they can experience those true healings, all the way from, I always say we've got just as many teenagers and 20-something-year-olds as we do 50 and 60-year-olds. Age doesn't really matter anymore. We have a 30-year-old that has Graves, lupus, and RA, and she's 30. We've got 21-year-old with MS, a 34-year-old with MS, probably 12 MS patients right now. Again, age doesn't matter. We had an 88-year-old this year, an 85-year-old as well, and they're vibrant, and they're going on vacations, and they're doing all kinds of things. So it's fun to be able to practice this type of model, and the thyroid is a perfect piece that fits into this. And we don't have thyroid protocols. So if you go in and you talk to somebody and you're asking about their thyroid, and they say, oh, great, we're going to do our thyroid protocol. Get up and walk out. Why? Because there is no thyroid protocol. And if they tell you there are doing one, or if you're going to read a book and go, oh, I got to take all these supplements because that's what the book says, or a blog post or whatever, that's not going to fix the problem. There is no one size fits all. I always like to think about it this way. If you have 10 people with the same 3 symptoms, thyroid, digestion, energy, right? They could all have different systems being out of balance. And vice versa. You could have 10 people with 5 systems out of balance, and they could all have different symptoms. Not necessarily the thyroid, not necessarily the fatigue, not necessarily the digestion. It could be other things, could be out of balance that way. So that's what we're looking at. We've got to get to that underlying why. We've got to get to that point where we know what is going on with the body. So tonight I'm gonna. Hi there, come on in.
So sorry.
Oh, you're fine. It's you made it at least. That's good. Yeah, there's a couple chairs in the back there. So this evening we're going to get in depth into thyroid physiology. I'm going to try to make it as learnable, doable, studyable as possible. But if at any point you need a little bit more information or you're a little confused, just let me know. But otherwise, I want to get through that. I want to show you some of the main reasons why we have thyroid dysfunction, and then educate you on some other paths that you may not have heard of, or you may not even be familiar with that process. So I am going to draw on the board a lot, so if you guys can't see it or anything, let me know, and I think I will move this one here, right next to that board. Are both lights on?
Yes, everything.
Okay, everything's on. Okay, all right. Where's the thyroid gland? In the throat. Good job. That's half the battle, right? All right, so basic thyroid physiology. Thyroid sits in your throat. They call it the what gland? What does it look like?
Butterfly.
The butterfly, right? So it's kind of shaped like a butterfly. So that, here's you. If you're in Colorado and it's snowing and you're cold, you're probably not smiling a lot tonight, but that's okay. Why did I draw the third eye up there? What's that? The pituitary? Have you guys heard that term before? The pituitary gland? So the pituitary gland is the master gland of the body. Why do they call it the master gland of the body? Well, because it's very, very important. The pituitary tells the thyroid what to do. It tells our adrenals what to do. That's cortisol, adrenaline, all of that, our stress glands. And it tells our male and female hormonal system what to do. So without the pituitary, people can't function, and they have to take all types of different hormones for it. How important is the pituitary in our evolutionary process? Very. So if you draw a line here and a line here and go straight into the skull, that's where it sits, in this little place called the sella turcica, or the Turkish saddle. It's this little cup, and that pituitary sits in there. It's that protected, probably the most protected thing in the entire body. So master gland of the body. The pituitary is going to tell the thyroid what to do. How does it communicate to the thyroid? A hormone, and that hormone is called thyroid stimulating hormone. Who's heard of TSH? Okay, and that's a very common way to test your thyroid, right? Well, I'm going to show you that it's not the best way to test your thyroid. Why? Because it's actually a pituitary hormone. And it's thyroid stimulating hormone. So what does that mean? Well, we need to stimulate the thyroid to kick out more T3 and T4, which we'll talk about in a second. So a lot of doctors have adjusted your thyroid medication based off of TSH, right? No? Most people have. That's what most doctors look at, is the TSH. As TSH goes up, we need more thyroid. As TSH goes down, you need less thyroid. But I'm going to show you how that, it can never be 100% accurate that way. And it's basically chasing the tail of the dog instead of grabbing it by the collar. So thyroid stimulating hormone is going to tell the thyroid what to do. So that would be like, the pituitary also tells FSH and LH. So stick with me here. These are both hormones that are going to tell the female cycle what to do, estrogen, progesterone. So if somebody's doing an ovulation predictor, if they're trying to get pregnant and they pee on a stick and see if they're going to ovulate, they're looking for LH. So determining the level of thyroid hormone somebody needs, like looking at TSH, would be like looking at FSH and LH. These eventually go into estrogen and progesterone. They tell the body to produce more or less of those. It'd be like looking at FSH and LH and prescribing somebody some type of estrogen and progesterone. That's what looking at TSH only and prescribing T3, T4, whatever it is, would be like. So we've got to take a step back and figure out, okay, how can we really know what's going on in the body as far as the thyroid goes? So what does that look like? Well, when we think about TSH, TSH is actually inverse to, in theory, what's happening with your thyroid gland. Meaning, as TSH goes up, the thyroid's actually too low. Inverse and then opposite. So as TSH goes down, it's usually because the thyroid is overactive. But that's making a lot of big assumptions in that the thyroid hormone is going to be getting to the cells like it needs to. And I'll be drawing through some different parts of this process here. Okay, so we have pituitary, we have the hormone that tells the thyroid what to do, and then what types of hormone come out of the thyroid? T3 and T4. Named for the number of iodine molecules coming out of there, so 3 and 4. So what we have is about 93% of thyroid hormone being produced from the thyroid is T4. About 7% is T3. What does that have to do with anything? Well, what type is the active form of thyroid? T3. So T3 is the active form, but we have to convert T4 into T3. So why don't we just make a whole lot of T3? Well, then you'd have a whole lot of active T3 floating around. Anybody ever been hyperthyroid? Take too much thyroid hormone? You like that?
Well, that was naturally.
Yeah, naturally. Yeah. Did you like being hyperthyroid?
I didn't know any different.
Yeah.
So.
Well,
It was awful.
it was awful. Yeah. Tell us what you felt like.
He wasn't
Like I was crawling out
No,
of my
I
skin
was-
and I wanted to punch someone in the face.
Yeah.
Constantly.
Yeah. Some people's eyes bug out of there, literally
Yeah.
pop out of their head. And, I mean, not all the way, but they're bulging out of their sockets. Their heart's going to be racing. A lot of people are like, oh, I'm low thyroid. Why can't I be high? I can't lose weight. And like, yeah, you're losing weight, but the body is literally just crawling out of its skin. So we don't want tons of T3 just floating around. So T4 is okay. So we're going to, I'm not an artist. So that T3 and T4 are going to get on a bus, and it's going to transport around the body to places like the liver and in the gut. About 60% of the conversion takes place in the liver, about 20% in the gut. So we are going to convert T4 into T3. It's a whole lot quicker and easier to convert T4 to T3 than it is to produce more thyroid. And so that's why we don't just make T3 from the thyroid whenever we need it. We need it floating around, and when we need it, we can switch it into these areas pretty darn quick. And then that T3 ultimately gets to our cells, and we get feedback. So if everything is working perfectly, this is going to say, hey, we have enough or don't have enough thyroid, okay, at that cellular level. And then, do we need more or less? The jockey is going to whip the horse to go faster or slower. But that's in a perfectly working environment, which very few people actually are, and there's a lot of other things that can start playing a role in here. One of them is what else is going on with the pituitary. So a lot of people that have low thyroid, do you guys know the ratio of men to women to men? It's about 8 women to 1 male for thyroid who has more thyroid issues. And I think part of it is because of the pituitary. And when you think about the other places the pituitary stimulates, the hormonal system, as well as the adrenals. You women have to deal with us guys. How stressful is that, right? And then hormones, menstrual cycles, babies, menopause, and what do we have to deal with? Well, we just get kind of old, and it's never fair. We always have women that come in, want to lose weight, and they're trying super hard, and they're down like 7 pounds. And their husband quit drinking beer every night and maybe changed a little bit, and what do they lose? Like 30. How fair is that, right? So yeah, you guys have to deal with this all the time. So women, just on the pituitary side, have a lot of stress going down that road. So one of the things that we'll see that can cause thyroid hypofunction is a hypopituitary, where the pituitary is not stimulating appropriately. So this is another one of those times where you can't just go off of TSH. Many times I see TSH, I think it's in this room. Many times I see TSH low and thyroid hormone levels low. And that's not because the communication isn't getting there. That's not because the communication's not getting there, it's because the pituitary's got nothing left. Years of trying to balance out hormones, years of stress, years of all these things, and the pituitary, that jockey's like, I can't even whip the horse anymore, and then the horse wanders off into the pasture, doesn't even finish the race. So a lot of times we'll see this hypopituitary be a big part of it, where the thyroid may be working just fine, and that horse is ready to go, but it's the jockey that's not whipping that horse to go. So we've got to figure out, is the pituitary dealing like it's supposed to? And if not, then we have to think about the adrenals, we have to think about the hormones, these other systems that need to be addressed in order for that to communicate effectively. Making sense so far on that top level? So then we get into the thyroid itself, and in here, just like that T3, T4 is made up of the iodine, iodine deficiency is a real thing, and that's why they make iodized salt, and then back in the 40s, 50s, 60s, people like up in, anybody from Michigan? You know, they would get these goiters. Has anyone ever seen a true goiter? It'll get like this big. So write this down. Google when you get home, thyroid goiter, and be thankful that you don't have one of those. Because it could be massive. Have you seen one in practice before? Yeah, I mean, and it's like, and some of them look like a basketball in their throat. So iodine is one of those. Tyrosine is an amino acid that is necessary for this to happen. So occasionally, the thyroid itself and those building blocks are not where they need to be. So then, in that person, taking some iodine, taking some herbs, taking some tyrosine, some of those could actually help. You're probably not watching this video, you're probably not sitting here listening to me if that would have happened, because a lot of people have tried some of these things in the past. But occasionally that helps, it's just not very often that's the whole story. And so that can affect where our whole T3, T4 production is down. And when we start thinking about most of the thyroid production, most of it's T4. And so if we have low T4, then we can usually assume that thyroid is not making enough, whether that's from lack of stimulation or whether that's from just the thyroid not being able to do it as well. So then this is the other part where you have to look at the different numbers, because a lot of times people will have plenty of T4 but not enough T3. So we'll see people at the upper end, or it'll even be high at that T4 level, but their T3 is actually low. What are a lot of docs going to prescribe if that's taking place? Cytomel, T3. Yes, you need T3, but it's way not the right answer. So here's T4. This is synthroid levothyroxine is going to be T4. Anybody ever been on the natural form of thyroid? Which one? Armor, Nature Throid, West Throid. There's been different ones. Some are harder to get now than others, and some come often on. What's the source of the natural thyroid?
Pig thyroid.
It's kind of weird, isn't it?
It's better than your
So some people feel better taking that kind, other people don't. But think about that. If we grind up a pig's thyroid and you eat it, so like my oldest and I, we just shot an elk a couple weeks ago. We actually each got one on the same day. It was kind of cool. And if I would have cut out the thyroid and ate that thyroid, I would have had tons of T3, T4. Okay, so what happens when you eat pork butt or bacon? Where does that go in your body? Anyways, so all over, yeah. So actually, I love bacon. I'm not saying don't eat bacon, but it's just one of those thoughts. So Armor Nature Throid is T3 and T4. So some people feel better with that, some people don't. I've seen a lot of different things, and there's no like, oh, I want to be on the natural form of thyroid. Well, it doesn't always work out for people that way. Okay, so some people will feel better with it, especially if they've got low T3, but some people won't. So just taking Cytomel is going to be here, and that's the T3. But again, that's really short-sighted in the whole scheme of things, because most people, if they have low T3, and especially middle to high T4, they are under converting. Okay? 60% of that conversion takes place in the liver, 20% of that takes place in the gut, 20% gets with some other processes go through there, but these are the two big ones that we see where we're not going to be converting that thyroid like we need to. So again, pretty easy pattern to see, and I bet at least 20% of the patients that come in with thyroid issues, we see an underconversion. Anybody ever seen a beaver dam? Pretty cool that they can do that, right? So you've got this beaver dam, and you've got your trickle of water coming out underneath here. That's your T3. Here's your T4. And so somebody said, oh my gosh, we've got low T3. Let's give you more synthroid levothyroxine. And you just build that dam up higher, and you get more T4, but you've still got that little trickle coming out underneath. So we've got to be able to break down that beaver dam and get it flowing underneath. And that's why, again, the thyroid may be working totally fine. It may not be a low thyroid issue at all with the underconversion. Somebody may not even be taking synthroid or levothyroxine, and their T4 is at the high end, and it's because it's dammed up and not getting over to that T3. So what do we need to work on? The thyroid? Liver, the gut. We've got to work on the transportation system, all these other things to make sure that everything is working as well as it possibly can to get down to that cellular level. So these are a bunch of the places throughout this whole path, and there's probably another 20 different blips that I could go through if we had a whole weekend seminar, where the thyroid could be working fine, but there's other imbalances. And this is what I'm talking about when we first sat down tonight, was 80% of what's going on inside of you is not your thyroid that's the problem. And for a lot of people we see, they come in and their T3 and T4 is actually totally fine. I had one lady today, she said, we were reviewing blood work, and TSH, if somebody's on thyroid replacement hormone, I like TSH about 1. And she was at 0.13. And she knew, she's been on it that long, she knew that at 0.13, she feels kind of like you when it's hyper. It's too much. And so they had changed some things and we're trying to get it right. She feels better about 1 to 1.1, which is pretty cool that she can actually tell when she's at that point. And so at 0.13, she was actually a little bit hyper. She had too much thyroid hormone in her body, yet she still has all these other symptoms that she came in for. She's still tired. She still can't lose weight. She's still got digestion issues. All this other stuff that is not because of low thyroid hormone. So we could double her thyroid hormone, bring in more, but she's already too high. That TSH is already too low, and she'd even feel worse, and it's not fixing any of those problems. So for her, again, same idea. We've got to take that step back. We've got to fix the underlying whys. Whatever's out of balance on somebody, that's what we got to fix. There's no magic, oh, here, fall into our thyroid protocol. I wish. 20 million people, we could fix them up real quick, right? But if that's all it took. All right, anybody ever watch the, was it like Worst Job Show? What's that called? Dirty Jobs or whatever. Yeah, I think one of the worst jobs I could imagine having is being an endocrinologist. No, any endocrinologists in the room? No offense if you're out there listening. God bless you, and you're trying to help people and all that stuff. But think about it. What happens when you guys come in? And your numbers look good. But what do you say?
Yay.
No, that's what they say. What do you say? I still don't feel good.
Yeah, what do I do now?
Yeah, I still don't feel good. But your numbers are good, yay! You know, and then they're off now. Ooh, let's change it. And so really, that dog is sitting there, and you ever seen one of those dogs, and it's like the whole rear end is just waggling that way, and you're trying to grab that tail? That's what it would be like. They must be one of the most unliked doctors out there, right? Because people come in every single day and like, I still don't feel good. What are you gonna do for me? And it's got to be one of the most disappointing office visits for patients, because why? If you've ever been referred to an endocrinologist, what are you thinking is going to happen?
I'm gonna get help, I'm gonna feel better.
So some help feel better, some kind of new whatever. What are we gonna do now? And what do they say? I don't know, or they tweak the medication a little bit. And no offense to them, because that's the model that they're in, and that's what they have to work with. And again, it would be a very frustrating position to be in, because in that traditional medical model, it cannot be okay to think outside of that box. You have to think about liability. We have to think about standard of care. We have to think about what insurance is going to cover, what medications, all these different things. So to think outside the box is very challenging in that system. And then who are they working for? They're working for a corporation or a giant conglomerate or all these things, and it's just not possible. And so people go to that endocrinologist and they think, oh my gosh, they're going to tell me, and I hear this from patients all the time, well, I'm going to get a second opinion from my endocrinologist, or I'm supposed to go see, and I'm like, okay, well, our door's always open, and when they tell you take Synthroid or levothyroxine or whatever it is, that's fine. Go ahead, and if that doesn't work, then we're always here. Because there is no magic level of thyroid hormone that's going to fix somebody. Sure, there's some that are going to make you feel better and some that are going to make you feel worse, but there's no, man, that fixed me now. Because there's the underlying whys. So all of these different steps along this thyroid path are going to be affecting how you are feeling, affecting how your brain's functioning, all those different things. And then, just to complicate things more, the research shows 70 to 80% of the people that have hypothyroid are also dealing with what? Autoimmunity, which is called what? Hashimotos. Anybody, who else has heard of Hashimotos? So, a few people, good. So, who named Hashimotos?
Mr. Mrs. Hashimoto.
Dr. Hashimoto's. It was like 1919, 1916, something like that. Dr. Hashimoto's found that the thyroid could be attacked. When did women get to vote?
Oh, gosh.
You want to Google that, Heather?
It's only 6.
Is it 19? It was like 1918?
It was the early 19.
Or 19.
Yeah, something like that. So like it's, which is just a crazy concept to begin with, right? Like 1920. That you guys, if it was 100 years ago, you couldn't have voted. You're like, really, were you not a person at that point, or it's just a weird concept. But 100 years ago, it's been around that long. You think about how long has it been since women could vote. You're like, oh, we've been able to vote forever, right? But we've been thinking about autoimmune to the thyroid for years and years and years, and yet, if one of you, maybe you've asked for it on your own, maybe you went to another doctor that was a little more progressive and tested for it, but how many of you on day one when you were worried about your thyroid went in and said, what do you want to look at? And they said, oh, we're going to run antibodies. A traditional, no, I'm talking your family practice doctor, your endocrinologist, you walk in on day one and they run antibodies. Just your, what's it? Yeah, I mean that
was a lab tech, so.
Yeah, and that was a lab tech that actually ran it. So the odds of that, but the odds of that happening are slim to nil.
Slim to none.
Yeah, I mean you're going to have a better chance of them checking for RA or whatever else. So it's not that the doctors don't care about what's going on. It's that it's not going to change what's going on. So Hashimoto's is an autoimmune condition, just like RA, MS, lupus, alopecia. You want to rattle off 20 more? How many known autoimmune conditions are there? Over 190. Third leading cause of death when you put them all together. Why would we put them all together? Well, that's what I'll show you here in a couple minutes, is that they all have the same underlying reasons why. Okay, so Hashimoto's autoimmune, and we think autoimmune to the thyroid, but that's not the whole story either. So what does the immune system do? So let's say you get this virus that comes into the body, and somebody sneezes on the door handle, you go over there, you turn that, you wipe your face, and you're like, oh no, I got a virus in my face. Okay, so the immune system is going to create antibodies to whatever is going on in the body. So we create an antibody to that virus and basically tag it. So if you're a Navy SEAL in Afghanistan and you put a laser pointer on this little hut and the drone comes in and blows up the hut, it's that laser pointer, it's going to say, this is where we want to attack. Then the immune system is going to come in and destroy that virus. Okay? So in an autoimmune condition, we start tagging our own tissue for destruction. There's 2 antibodies. I should have asked, how many antibodies do we test with Hashimoto's? 2! Good job. You get your special bonus. So why do we test 2? Because there's 2 different tissues that are being attacked. One, anybody know the names of them? TPO and that's the thyroid peroxidase, and TG, thyroid globulin. So TPO is here, and this is the thyroid globulin. So the bus. So we have TPO, which is actually the thyroid itself, and so we're attacking that thyroid, and thyroid globulin is the bus that transports it around. So we can destroy our own thyroid tissue, but we can also shoot out the tire on the bus and not transport it around. And I'll see it, some people have this one, some people have this one, and some people have both. We see more TPO than we do thyroid globulin, but we see at least 75% as much thyroid globulin as we do TPO. And sometimes I'll see thyroid globulin without TPO. Guess what? They're not actually attacking their own thyroid. They're not transporting it around the body. So again, 70 to 80% of the population that have hypothyroid are dealing with Hashimoto's. And when I get done telling you how this is affecting everything, you're gonna be like, why didn't I get tested on day 1? Well, what is the modern medicine solution for autoimmunity? Prednisone, Humira, methotrexate, low-dose chemo. Anybody want to go on those? You thought hyper was bad? You know, that's even worse. So in that model, the solution is worse than the disease. So what do we want to do? Well, we're going to, no matter what, in that traditional medical model, we're just going to give thyroid hormone whether it's Hashimoto's or not. So again, going back to that endocrinologist, me feeling sorry for him, they still only have this at their disposal. Even if it is an autoimmune condition, they're not going to suppress that autoimmune reaction. Why? Because it's, who's been on prednisone? Nobody in the whole room? Nice. Have you known somebody that's on prednisone? Yeah, what happened? Blow up, their face gets puffy, their blood sugar, we have people check blood sugar all the time, we'll see 20, 30, 40 points higher. Heather, did you? Mm-hmm. Heather swallowed a yellow jacket and her tea, and it went down and stung, and so that was what, a month ago? Yeah. And so they put her on prednisone because it was expanding everything, and we tracked blood sugar. What were you seeing?
40 to 50 points higher.
40 to 50 points higher on her glucose levels being on that. What does that do to inflammation? All these other things. So, and that's prednisone, which is kind of like, that's thrown out like candy sometimes. But we're talking about even Humira, $10,000 a month drug. You see that commercial on TV? for autoimmune, Humira, and $10,000 a month. So, those are not going to be used in this because no one's going to die from Hashimoto's. You may feel like crap, and you may never be your ideal weight. You may never have your ideal energy and all these different things, but you're not going to die from it. But here's the big concern. The longer somebody has Hashimoto's, the longer somebody has an autoimmune condition, the more likely they are to have multiple. And that's the biggest thing that we see. The research shows if somebody has one autoimmune condition, they're well more than double as likely, 50% higher risk of having multiple autoimmune conditions. And we see that all the time with people. So if somebody is dealing with Hashimoto's and they've been dealing it for 5, 10, 15, 20, 25 years, almost for sure there's other tissue in the body being attacked. And that's the stuff we don't want to go down. My mom having MS, all those different things. My wife had autoimmune platelets and they removed her spleen. All those kind of things. It would be much better to catch them back here than here. I diagnosed in the spring 3 teenage girls with Hashimoto's in the same month. Thank goodness we caught it then versus when they were 50. But what triggered it? Well, that's what we're going to be talking about here because that looks like a mess. Let me clean this up a little bit. Okay, so what does this do to everything else that we're talking about? Well, think about this. Why can we not base, if somebody has Hashimoto's, we can't base medication, anything, just off of TSH, obviously. But even if we do have Hashimoto's, we can't base it just off of the T3, T4 either.
No, it's the best method.
It's the best method we have for now, among other, besides symptoms and things like that. But get this. If somebody's attacking and destroying their own thyroid gland, what are they breaking down? Because if we destroy pig thyroid, grind it up, what do we get? T3, T4, right? What happens if we break down and grind up our own thyroid? We're going to be spilling T3, T4 into the bloodstream. We got more T3, T4. What's that feedback going to tell TSH to do?
Go down.
It could go down. And then the doc looks at that and says, oh good, you're doing better, your TSH is coming down, but guess what? You're in an autoimmune flare and you're destroying more tissue. Or hey, let's calm your autoimmune down. You read Isabella Wentz's book and watch the videos and you're like, oh, I'm going to go on autoimmune paleo diet and all this, and you calm your immune system down, and then you're not spilling out over as much T3 and T4 into the bloodstream. And what can happen? Your TSH goes up, and then your doctor goes, oh geez, this is bad. We got to give you more. But you just did a whole lot. You actually calmed down your autoimmune reaction. And so that is why it is not an apples to apples comparison at all for even if there's Hashimoto's, T3, T4, or our TSH or anything. That's not to say that we don't look at them. We look at that stuff all the time. But we cannot just go off of those numbers and say, yes, we're succeeding or failing. If you tested your TSH, especially with Hashimoto's, every week for a year, it could do that. You want to be the endocrinologist that tests TSH every week? More, less, more, less. You'd be all over the place. So, what does that mean? Well, any questions on that? Can we call that basic physiology? Any questions on the basic physiology? Is it making sense? I don't expect you to remember every little detail. Hopefully you're taking notes, and this is going to be on our Facebook page if you want to go back and watch it again. There's physiological reasons why things aren't working like they should, and it's not just a low thyroid state. And there's a lot of other systems that are going to be affecting it. When we think about autoimmune, it doesn't matter. A couple weeks from now, I'm going to be doing an autoimmune workshop. We'll probably have 10 or 15 different autoimmune conditions represented in the office. It doesn't matter what somebody comes in for. We're going to look at it from the same perspective. what is driving that immune inflammatory cascade? It is not just that immune system going haywire. That's a simplistic approach, and just to suppress that immune system, that's not fixing anything. One of the first places we always look is blood sugar. My latest book, Blood Sugar Doesn't Lie, I named it that because I've said that to patients for years and years, but most people are thinking about that and they're going, oh, well, this isn't me, I'm not diabetic, right? That's probably your first thought, or I don't eat sugar. But guess what? Blood sugar, it's not just about high blood sugar. Just like hemoglobin A1C, we don't just check hemoglobin A1C to see if somebody's diabetic. We look for a lot of different reasons. Blood sugar, highs and lows are just as problematic. Dr. Karazian, he's the godfather of Hashimotos. Everybody that teaches out there or writes books, they've trained with Dr. Karazian. And he's always said, every time that blood sugar goes up too high and down too low, we rev up the immune response and we destroy more tissue. In this case, either the bus or the thyroid. But if you've got MS, it's going to be the myelin sheath. If you've got RA, it's going to be your joints, any of those things. Blood sugar swings, highs, and I would say even especially so lows, because it's driving the adrenals and that cortisol, adrenaline response, this whole cascade to rev up that immune system. We're going to destroy tissue every time we're doing this throughout the day with our blood sugar. So for almost every one of our patients, we have them start checking blood sugar.
Quick question
Yeah,
for
yeah.
you. So why is there an immune response when your blood sugar goes down or up? To me, like, it just doesn't make sense. Why would your immune system kick in?
Yeah, so it's the immune inflammatory cascade that gets stimulated. So when it goes down, the body, that's a kidney, the adrenals sit on top of the kidneys and they stimulate the liver to kick out stored glucose. And,
Gotcha, okay.
and
if it's too high,
then insulin, that
Gotcha.
insulin response, insulin's going to drive, it's inflammatory, it's going to drive that immune response as well.
Because immune, when I think of immune, I think, oh, like, bacteria's in there, you
Yeah.
just got a cold or something.
Right.
But it actually responds
It's,
when you have...
and I call it a immune inflammatory cascade. So this
Gotcha.
whole cascade goes down the pathway. And
Interesting.
that's why if you look at monocytes, one of the blood work markers for the immune system, those can be both infection and inflammation. A lot of those can be going down both pathways.
Gotcha.
And so we get adrenaline, cortisol, that whole adrenal cascade, and revving that up. And then we get up high, we get that insulin response, and that's going to be very inflammatory. That's why they call Alzheimer's what?
Diabetes type 3.
Type 3 diabetes. Because that inflammation and immune, and even Alzheimer's has an immune component to it as well, attacking the brain. Neuropathy of the hands and feet with diabetes, well, you don't want neuropathy of your brain. So blood sugar, one of the crucial parts for us. We always say though, adrenals and stressful events, that can, if you've known anybody that got really sick or really run down or whatever after a very stressful event, that can drive that autoimmunity as well. But with this adrenal stimulation there, we always say the number one stressor to the adrenals, no, don't look at your spouse, it is going to actually be blood sugar swings, and especially these lows. So those blood sugar highs, but especially the lows. What can that feel like? Well, when those adrenals kick in, we can feel jittery, we can feel some, I call it random anxiety. I did a video a couple months ago on that on Facebook talking about random anxiety where it just hits out of the blue. And a lot of times that's low. What happens if you're sleeping and that happens? Adrenaline. Hey, my mind's going. That could be a nightmare. Some people wake up with a hot flash. Some people wake up with their heart racing in a pool of sweat, whatever, and they're like, oh my gosh, I must be stressed about something. All right, who's not stressed about something, right? Look, we live in America. We've got jobs and cars, and whichever president's in office you get stressed about, whatever it is, we can stress, and yet not everybody wakes up freaking out in the middle of the night. But a lot of people do. So blood sugar, adrenals, especially in the female side, estrogenic events, but hormones in general are going to play a role in this. I was working on a lady today. Her 13-year-old son has juvenile arthritis. It's autoimmune, and was doing well, and then just in the last 3 months really flared up. Well, he's 13. Guess what he's going through? Puberty. So we've got to make sure the body's clearing those things out. There's something that we call leaky gut. And it sounds kind of a new agey term, but leaky gut is the small intestine lining is irritated, damaged, not closing like it's supposed to, and we're absorbing things in. Think about our digestive tract as still the outside of our body. So remember when you were a kid, did you guys have in those balloons that were filled with water and you'd squeeze them like this and they'd go bloop and keep going like that? So if I grabbed Heather and I squeezed her real hard and her insides came out and her outsides went in, it would still be the barrier. And then her skin would be the inside, but it would still be the outside of the body. And that's basically what we are. This tube going through us is still a barrier, still the outside of the body. So if somebody comes in, they've got a lot of open sores, things like that, that's what it would look like in that digestive tract. And we've seen upper GIs done and different things, and you can see it in there, how irritated it is. And so let's say, I think I'm going to go up to Rocky Mountain tomorrow with my 8-year-old and might do some snowshoeing, and you go into that pit toilet, and you're on your phone, you're like, oh! And then you have to stick your arm in and get it, and you got these big open sores in there. Yeah, that's what's going to happen in our digestive tract, is we're going to be absorbing things into the digestive. What? Was that too much? Too much? So you're going to be absorbing stuff into the bloodstream way too early, and it's going to create this immune inflammatory cascade. And it's going to say, oh, there's a little thing that normally that gluten wouldn't be a big deal, but hey, let's shoot it with a bazooka instead of a BB gun. So that gut is a huge, huge part of it. Vitamin D modulates that immune response, meaning it turns it up, turns it down. We've got to have optimal vitamin D levels. Where do we want those? Anybody know the
32.
functional medicine range? What's that?
32?
That's what the lab range is.
Okay.
Functional medicine range is 60 to 80. And the number of times I see that on somebody without taking medication, I was going to do a 0, maybe 1 or 2, and we've looked at thousands and thousands of blood work. Coming in from infection side of things. If somebody gets a major infection, I've got a patient comes down from Casper, she had a mosquito bite, this was a couple summers ago, and it triggered an autoimmune cascade, not sure if it was West Nile or what it was, and same thing as my wife's, that started attacking its own platelets, and she went from needing infusions every 6 weeks to every 9 months, and we were able to calm that down dramatically. So infections can just overstimulate that immune response. Environmental exposure. So sometimes if somebody's doing a lot of heavy metals, chemicals, even moldy houses, and a lot of people are like, oh, good thing there's no mold in Colorado. Guess what? One of my patients just brought in he did a mold test in the basement, and his humidity was like 60%. In his basement, I've seen 70-75% humidity in people's basements. I had a lady earlier, what's the airbed? Sleep number. Yeah, they had a recall on them a bunch of years ago because they were not breathing appropriately or something, and all mold underneath there. She pulled it up, all mold. Oh, they sent you a new one, great, thanks. But now you've stimulated this immune inflammatory cascade that has to be downregulated. I had another patient, she had a Tempur-Pedic or a knockoff of it, and they went to move, and in between there, because those sleep pretty hot, soaked through it, all mold under there. Another patient lived in a basement in Fort Collins here, had a basement apartment she rented, had her paintings underneath that she'd been working on. She went to pull them out, and the mold was actually eating away the painting. Opened up the stairs underneath there, mold all through out there. I got story after story after story. So for 25% of the population, they're screwed, and that is going to stimulate that cascade. 75%, great, you'll be okay. Good old genetics, right? Then you have to not just get out of that mold, because that whole cascade has been stimulated and driven, and everything else has to be brought down. I'm forgetting one here. Oh, everybody's favorite, That says gluten for you guys out in the internets. Gluten, everybody's favorite, right? Well, is that really a thing? Well, go read Dr. Karazian's book, and he's got the research in there that shows for every time somebody eats gluten, it mimics the thyroid gland, and it'll stimulate destruction of that thyroid gland, not just at that one time, but for how long? Have you ever read his book? It's one of the best books out there. 6 months. Up to 6 months it'll stimulate that. So, I just eat gluten once every week or two. Well, you might as well eat it every day and enjoy yourself because it's still going to be driving that immune cascade. I could keep drawing lines off of this, but I'd keep you here guys late. I know you've been very patient listening to me ramble on about all this thyroid stuff. So if we're dealing with Hashimoto's, again, at that point, it's totally not the thyroid. That's the problem. Yes, the thyroid's involved, but it's like the thought process of saying, oh, you've got MS, so it's a nerve disease. You've got RA, it's a joint disease. No, those are autoimmune diseases that are attacking those areas. And that's what Hashi's is. So first, you've got to rule out, do you have Hashi's or not? Second, what are you going to do if you do? Well, you've got to downregulate whatever shows up. So again, somebody may be anemic that comes in. Somebody may have low iron. Somebody may have high iron. Somebody may have a virus for their infection. Somebody else may have a bacterial infection. Somebody may have high blood sugar. Somebody else may have low. Somebody may be flip-flopping all around. So it's very individualized. There is no Hashimoto's protocol. There is no thyroid protocol. And hopefully after you saw that whole scribbling I was doing with the thyroid, you can see how every little step needs to be working just right. Because everything could be working perfectly, but if your liver or gut is off and you're not converting, you could have triple the amount of T4 that you need, but it's still not going to do what it needs to do. And so that's where we go with patients, is we've got to start on that level of where are those underlying imbalances. We didn't even get into the brain, and if the brain's in this chronic fight or flight and sympathetic dominant, then there's no way you can be digesting, and all these other things are involved. And that's why we've got probably $200,000 worth of equipment in this office for a lot of different things to help repair, rebuild, stimulate the vagus nerve, calm down the sympathetic dominant state, all these different things to be able to change people's state, change people's lives, and not just, hey, let's give a medication and calm things down short term, or let's go natural. You're not sleeping, take melatonin. Did we fix it? No. Even if you're sleeping, we didn't fix it. So we've got to fix that underlying why. So I'm going to stay for a while after we get done, and you guys can ask any question. Feel free to ask questions online as well. We'll be answering questions on there. And the big thing I want you to leave you guys with tonight is no thyroid, Hashimoto's, whatever, we're not going to die from this. 2 weeks you come back and there's some autoimmune conditions that people will be here with that they truly could die from. My mom, if she would have not got the healing that she did, she would not be here. My kids, 8 to 15, 4 boys, bless my wife's heart out there, they wouldn't know grandma right now if they had not gone down that path of truly healing what she had going on. I guarantee she wouldn't be alive right now. And so there's those extremes. And yet, can you live to your fullest? Can you live to your full vitality and change the world and do those things that you want to do? It's pretty darn hard when you fill out that whole list of low thyroid symptoms, or then you spill over to high thyroid and you actually punch somebody. Would say you
I started there, but yeah.
You wanted to punch somebody
that's how I felt.
in the face. You know, that's probably not constructive.
My face still hurts.
Yeah, I know. I was gonna say, what happened, buddy? So yeah, that's really what drives us every single day. We've got a great team. We've got Deb, our nurse practitioner, that can help manage medications. We've got nutritionists. We've got our therapists for brain work, for everything that we can possibly do to get people's lives back to where they are. And that's what drives us. That's our passion every single day. So what I do with new patients is have you guys come in. We do an in-depth neurological metabolic exam, different than anything you've had done before. I'll be pinching your toes, shining a light in your eyes, a little different than anything you've had done before. Okay. We'll be looking for the body to tell us what's out of balance, not just what some doctor said, not just what your symptoms tell us, but what's your body doing. Then we do a brain map and we figure out, is it in that fight or flight state? Are you getting the good sleep that you need to be? All these other things that may not just be low thyroid symptoms that are affecting your brain, it could be your brain affecting other things. And then we sit down, look at the blood work, and I let you know exactly what's going on. If I think I can help, great, we'll go forward with it. If not, I'll get you to the right person. We're a very busy office. We don't need to work with people that I don't think we can help or that aren't totally motivated and ready to get their lives back. That process is pretty in depth and takes multiple visits, multiple times of interacting, and yet for the people that truly want to get their lives back, that's where we've got to start. If we were going to add all of that up, probably $600 or so for all of those together, but I don't want to rule anybody out until I know for sure that I can help them or not. So we do that for $97 for that initial examination, the brain map, looking at the blood work. If somebody has insurance, that can be as little as $70, and that's looking at antibodies, at inflammatory markers, C-reactive protein, homocysteine, fatty liver, all these different things that nobody else is looking for. So we're looking at those, looking at the exam, doing the brain map. I'll sit down, let you know exactly what's going on, and then if it looks like something we can help with, I'll let you know what that process would look like. So for anybody that wants to jump on that, Heather's got a list of available appointments, things like that, and we can get you in and out and get you home quick tonight. But if you have any other questions about any specifics, anything like that, feel free to come up and talk afterwards. But hope you guys learned a lot and you know, are stimulated and inspired to go and take more action. So, all right, have a great night.
Thank you.
Yes.
Thank you.
Good. Just hit the stop button.
There is no stop
Oh,
button.
finish.
It won't.
Oh, I'm running out of juice.